Okay, ladies and gentlemen, welcome to another very interesting industry-sponsored symposia. As I mentioned yesterday, these industry-sponsored symposia are much more science symposia than commercial or corporate symposia. All the industry in this field, I must say, have been really collaborative in integrating the program rather than, proposing specific commercial messages. And I think it's extremely important for us to know what is available today, what are the products, and also a little bit how these products are generated, produced, and managed in different parts of the world. We have a very nice group of speakers. The first in particular is very good. That's me. I'm sorry, I'm joking. At the end of this meeting, I'm completely, destroyed. So I hope you forgive a little bit of jokes. What I wanted to tell you is that the dimension of adsorption is a completely new approach that we have investigated in the past for intoxication and so on, but only recently has become a very important integration to the membrane separation process that we have studied for years in dialysis using different membranes, including high cutoff membranes and so on. Even new membranes have adsorption capacity, but it makes a lot of sense to use sorbents, which are particularly beds in which we can circulate the blood to try to remove substances that are hardly removed with other mechanisms. So I will present today the case for a series of sorbents, in particular the HA330 and 380 cartridges produced by Jafron, and I would like to thank Jafron for organizing this meeting. I must say that this well incorporates in the concept of sequential therapy that I have recently proposed for patients with sepsis. We know that sepsis today is differently defined from what has been in the past, and our definition today includes the concept of a specific organ dysfunction, and the organ is our immune system. There is an immunodysregulation that leads to uncontrollable inflammation or uncontrollable immunoparalysis. And so the syndrome ends up with specific organ dysfunction and death. Septic shock is the most severe situation in which endothelial dysfunction is the mainstay of the syndrome. And in fact, these patients have a capillary leak syndrome and have an intractable hypotension. Mortality rates is very high. This is the sequence that we have in sepsis. We start from an infection. We have the bacteria and the endotoxin, especially captured by LBP, which is a specific lipoprotein binding protein, and then activating the CD14 receptors with the activation of different mechanisms in the monocytes that may result in cellular and humoral effects. And when these effects go to systemic level, the endocrine effect of mediators may lead to different organ dysfunction. So it makes a lot of sense to consider every patient as a potential patient with different level of derangement at different stages of the syndrome. At the beginning, the best solution would be to make source control, because if you control the source of infection, you are likely to resolve the problem or to remove endotoxin. But the major derangement that occurs in this patient is the so-called cytokine storm before leading to organ dysfunction. Now, how did it come that we could apply extracorporeal therapies to generate some immunomodulation? Well, the reason for this is that many of these septic patients ended up with acute kidney injury. And in the past, they were treated for acute kidney injury with extracorporeal therapies. And suddenly, we started to see some benefits in terms of less need of vasopressor support, improvement in blood pressure. So there was the idea that extracorporeal therapies may be beneficial for the septic patient. Now, leading to the concept that you can remove different substances, as you can see here, in this case, this company has produced different type of sorbents. Hemoperfusion is a therapy that has been done since the very early 60s, last century, but only recently we have available cartridges with a higher level of biocompatibility. And in fact, there are now cartridges for specific removal of solids in chronic kidney disease, in acute poisoning, intoxication, in immunodisease, and finally in sepsis. This contains specific synthetic resins, which are different from the usual alumosilicates or carbon sorbents used in the original hemoperfusion. And you can apply this quite easily in series with the dialyzer in your patient on CRRT. And I just wanted to put this pressure control that we had during treatment, showing that there is no change in end-to-end pressure drop in the circuit, and you can easily apply the cartridges. Different indications have been identified, not only sepsis, but also in polytrauma, pancreatitis, ARDS, in cardiac surgery, especially linked to the ECMO circuit, with the possibility to remove pro-inflammatory mediators in the moment they are generated by the on-pump surgery. Well, these are the technical characterization, but you can easily probably visit the scientific exhibition outside and get information. These columns contain neutral microporous beads. They have different pore size that, however, allow to remove molecule up to 60 kilodaltons. And in fact, the surface of these resins are incredible. Just imagine 1,000 square meters per gram of substance. So the adsorption surface is really enormous. Here you see two different circuits in which the cartridge can be used in series with the dialyzer or as a standalone system. It is extremely important, of course, and this is confirmed by transmission electron microscopy, that the surface is biocompatible in order to avoid any type of side effect. But at DRIV, we don't trust anybody. So we wanted to do our own test, and we did our in vitro cytotoxic evaluation of the sorbent. And we used a specific machine that we created. We call this machine Galileo because it allows us to look at the stars and the black holes of any type of device. And so we did static test and dynamic test. Basically, we incubated the cells which are very sensitive. These are monocytes from an in vitro cell line with the cell medium that has been either sitting with the resin or circulated in the resin. And then we used a specific method using cytofluorimetric assay by annexing 5 and fit conjugated kit. And there was no activation at all of monocytes. So my first concern was, are these cartridges safe? And they are. They are biocompatible. We have no complaints from both static or dynamic tests. The other thing we wanted to see is, am I utilizing the whole surface available for this? And in fact, we did a specific CT scan of the circulation. Here is again our cartridge perfused with blood, and we studied the perfusion of cartridges in different surfaces and different flows and different conditions, and the utilization of the cartridge is practically corresponding to a plug flow. As you can see here, the full amount of sorbent is utilized for adsorption, and once you end up the circulation, the cartridge becomes very clean, and while you're utilizing the cartridge, it is fully replenished with blood in all the different areas available. We did different studies, and we published this in Blood Purification. If you are interested, I think it's open access, so you can easily access the papers in Blood Purification. Also, we studied the pressure drop, which is extremely important to know, especially when you try to go to higher blood flows. Here, although the company, I think, suggests a blood flow in the range of 200 or 250, we tested the cartridges up to 400 mL per minute, and we found no side effects, no special increase in pressure drop, except what is expected according to the Hagen-Poiseuille law. So we then made also a revision of the literature together with our own experience, and we have seen the different possible applications of this new cartridge in different septic and acute and critical disease conditions, including the connection with the cardiopulmonary bypass in cardiac surgery. As I mentioned recently in the Meet the Expert, it's very tough to say whether a treatment like this impacts mortality. Maybe mortality is not the right endpoint for something you're doing today, and then you're looking for an effect in 90 days. What a system like this should do is exactly to do what it claims it does. Exactly removing, for example, cytokines. And different studies have shown, as in this case, for example, in septic patients, removing very well interleukin-8 and interleukin-6. In this case, once again, you see in 46 patients with acute lung injury induced by extrapulmonary sepsis that the treatment with hemoperfusion with these cartridges induced a significant difference in the concentration of interleukin-1 and TNF-alpha in the BAL and in plasma. We also have studies from different parts of the world, including Germany, where it shows a decrease in interleukin-1 beta, interleukin-6, TNF, and in some cases like this, we have a signal of a slight change in 28-day mortality. In particular, especially in patients really ill, for example, this patient with epidermal necrolysis, there was a retrospective cohort study that showed a different effect of the hemoperfusion combined with continuous renal replacement therapy, and in particularly higher 28-day mortality, higher 28-day survival, of course, not associated with higher cost in general, because probably you can save money on the length of stay in the ICU and in the hospital. And in fact, there is a kind of improvement which is quite rapid in the clinical condition of the patient. Other aspects that have been investigated, for example, in hyperlipemic pancreatitis, have been showing a better control of the lipidic derangement in these patients. And one of the questions that has been raised, and again, it's an open question, is what is the kinetic of these cytokines? We don't know how much is produced, we don't know how much is metabolized, how much is eliminated by the kidney, and how much I need to remove with the cartridge. So what we have learned, however, is that the cartridge, approximately around the 12 hours, starts to show a plateau in adsorption, which may suggest to change the cartridge a little more frequent than what it is suggested. This is from the clinical perspective. However, because we cannot biomonitor our patient, we need to extend the coverage of cytokine removal as long as possible to prevent peaks. This introduced the concept that I somehow described years ago of the peak concentration hypothesis. And the aspecific removal in this case is an advantage because it removes whatever is at the very high concentration in blood, somehow cutting the peaks and bringing the patient to a better immunohomeostasis. In fact, in patients treated, we have studied the monocyte activity. And it is interesting because the septic patient has a kind of paralysis of the monocyte. But when you treat the patient, as we have seen in the past a little bit, not only you have a decrease in the vasopressor support requirement, an increase in blood pressure, but also you have a restored response in the monocyte when the monocytes are incubated with LPS. Plus, the monocytes are presenting a better phagocytic capacity, and one of the most interesting aspects is the presentation of the antigen, which improves as demonstrated by the increase in HLA-DR expression. So, when you have a very critically ill patient, you have to be ready to support also all the different organs that are somehow involved in the septic syndrome. So you have to support the liver, you have to support the kidney, but before that, you have to create the condition in which no further damage occurs in our patient. We have published recently in JAMA this concept of ECOS, extracorporeal organ support, where we showed clearly that we can support the lung, the heart, the kidney, the liver, but certainly there is one common denominator that sorbents can help us to do, and it is the removal of the cytokine storm in the septic patient before and during this insult to different organs occur. So today we know that different organs interact. We speak about the organ crosstalk. You must have followed some presentation in this meeting where you have seen that lungs and kidneys speak, heart and kidneys speak, and they interact. Today, using the extracorporeal organ support, we also have to learn a new physiology, which is the interaction between different artificial organs. For example, I need to know what the interaction between an ECMO and my organism is, but also the interaction between ECMO and dialysis, or ECMO and adsorption, or adsorption and ECMO. So it's a totally new physiology that we have to learn. So coming back to my sequential approach, I think that the best approach is probably to design a treatment for a patient which is specifically for that patient, but also for a specific moment in the life of that patient. And the moment in which cytokines are spreading out is probably the moment in which you can do something to prevent organ failure. I think that we described this some time ago, the idea of dynamic prescription, as we do for let's say metabolic wastes like creatinine and azotemia. If you prescribe 20 milliliters per kilogram per hour, and then you see azotemia climbing, then you have to be ready to reprogram your prescription and probably to increase the dose of dialysis. Now, we need to come up with the biomonitoring system that tell us where we are in terms of endotoxin and cytokine concentration so that we can somehow modulate our prescription for treatments like immunoadsorption or adsorption of cytokines. And in this case, we will have a significant response. So the future of interventions, in my view, will be an integrated and sequential approach with pharmacological approach still, timely endotoxin removal, but we need to monitor endotoxin assay, immunomodulation by hemoperfusion, and we have the devices now, adequate organ support, extracorporeal organ support, and also conditions that favor organ recovery. So every patient will require a personalized therapy, what we call precision sequential extracorporeal therapy. We need to identify the population that we treat and identify specific targets. Otherwise, we will just treat everybody and we do not have the right answer. We have to identify endpoints for clinical studies. I know that there is an ongoing study in China with a large utilization of this cartridge, and I'm very curious to see the results of this study. To adopt dynamic prescription criteria, possibly to drive our decision based on biomarkers, and use sequential extracorporeal therapies. With this, I would like to conclude my talk saying that I had the privilege recently to visit the Jafron company in China, and I was impressed by the quality of production, the attention to the clean level of production of the devices, which somehow confirm that our studies on biocompatibility and quality are correct. I think that we need this confidence because our first concern for patient is safety. And this is very, very important. So thank you very much. And I would like now to move to the second speech of this section, which is Professor Romina and Danguilan from Philippines, speaking about sorbent technology application in a tertiary renal care hospital in the Philippines. So, thank you very much. Please.
Thank you very much, Dr. Ronco, and I'd also like to thank Jafron for inviting me to give this talk to share with you our experience in using sorbents in the treatment of leptospirosis. The lecture now is not my lecture. Could you put it to the other one?
It will come.
So our hospital, the National Kidney and Transplant Institute, is a tertiary 380-bed corporate public hospital, and we specialize in renal, urology, vascular diseases, and organ and cellular transplantation. And the sorbent cartridges became available in the Philippines only last year. And so we have some experience using the 130, the 330, the bilirubin, and ammonia cartridges. Leptospirosis is a very severe disease that affects our country. It's a bacterial disease that results upon exposure of mucous membranes to urine of infected animals, and usually these are rats in urban cities. Here you see a picture of floods occurring. And the most severe manifestation is Weil's disease, where you have jaundice, renal failure, and pulmonary hemorrhage. And the leptospirosis cases in the Philippines last year really increased a lot, maybe because of a very poor prophylaxis that was given. Here you can see that the peak areas are the rainy months, and that starts in June up to September. And because of the surge and the increase in the number of patients in our hospital, we even had to convert our gym into a leptospirosis ward. We had 436 leptospirosis patients who we had to admit in 2018, and this was a big thing. It was headlines in our local papers. And since the patients all came in with kidney failure, we even had to set up a 5-station for hemodialysis right there in that area so that we could easily dialyze the patients when they needed the treatment. And so leptospirosis presenting with renal failure is often accompanied by pulmonary hemorrhage and carries a high mortality despite standard therapy. And there's an increasing evidence for an immunologic mechanism mediating both these complications. And therefore, we changed our protocol over the last few years. Aside from giving conservative therapy and antibiotics for leptospirosis, we also gave them methylprednisolone and cyclophosphamide as our treatment protocol since 2014 to improve overall outcome. In a review of 194 patients from 2014 to 2016, we found that 25% of our patients died. 16% were due to pulmonary hemorrhage, 7% due to multiple organ failure, and 2% due to hospital-acquired pneumonia. And significant predictors of mortality were a low platelet count, prolonged prothrombin time, and parenchymal infiltrates on chest X-ray. Now, if you look at the causes of morbidity or mortality, we find that primarily the patients were dying from lung hemorrhage and sepsis. Now, what was the outcome? Renal function recovered within 2 days of treatment with renal replacement therapy, using our pulse therapy, antibiotics, and supportive care, regardless of mortality. So we're pretty sure that renal function will recover. But we still had our causes of death. So in our paper, in this study, we found that for pulmonary hemorrhage, we might treat that by the use of ECMO for lung support. However, we looked at sepsis and what were we doing for the sepsis part. So for therapies in sepsis, to remove excess fluids, acids, and waste products, we use our renal replacement therapy, and that's through diffusion and convection. And now we felt that we needed to remove something more to have a more effective treatment for this disease, to remove pro-inflammatory cytokines, possibly IL-1, TNF-alpha, and other mediators. And we would do this using hemoperfusion or coupled plasma filtration adsorption as necessary, using adsorption now as our mode. So we had a change in treatment protocol again last year for severe leptospirosis. If patients presented with severe pulmonary hemorrhage and ARDS, respiratory failure that was not treatable with mechanical ventilation, then we would provide them ECMO. And for sepsis, we would provide them hemoperfusion aside from renal replacement therapy. In 2018, we had a total of 436 patients diagnosed with leptospirosis, and overall mortality was 15%. There were 66 patients who died. And again, now the most common cause of death was still pulmonary hemorrhage. And we present our data on 7 patients who were given our protocol, ECMO for lung hemorrhage and respiratory failure, despite maximum ventilatory support, and hemoperfusion and DP mass as indicated. And this study, or first case, was published recently. We looked at the case reports for use of ECMO in leptospirosis, and here are some of them from 2015 up to including our paper. And ECMO access was usually VV ECMO, and approach was either femorojugular or femoral. We used femoral in our patients. And here the days on ECMO range from 16 to 18 days. In our patient, or the first patient, we put him on ECMO for 6 days, and all these patients were recovered. So from this, we found that leptospirosis in its most severe form could be treated with ECMO. And for our own cases, we had 7 cases, mean age of 34 years. All were male, presenting with hemoptysis and infiltrates on X-ray. You can see that ages range from 26 up to 47. And although most of them presented with both a low PO2 and a high CO2, there were some patients, patient 1 who presented only with a low PO2, and patient 3 who presented only with a high CO2. These were the baseline labs, and consistent with Weil's disease, we had a very elevated PTT as high as 67.3 seconds. Hemoglobins range from between 11 to 14, showing it's quite an acute illness. WCs were elevated, and platelet counts dropped to as low as 40 in one of our patients. Creatinine, all of them had elevated creatinines on referral to us, except for patient 2 with just a slight elevation. Procalcitonin, which normal in our lab was less than 0.1, and here it could even be more than 75. We also tried to look for another marker to help assess how our patients are doing and how we would monitor response to treatment. So we used HSCRP. Normal is 0 up to 3, and here you can see they're very, very high as 261 in patient 6. We also found that these patients had very severe acute pancreatitis. In fact, one of them had necrotizing pancreatitis. So when we started with patient 2 onwards, it became routine for us to do a baseline amylase and lipase, and as you can see, they were very, very elevated. We also used Apache and SOFA scores to look at how severe the patients were. And also, this might help us later on to determine who we would put on ECMO and who we would apply HP on. And here was how we set up the ECMO. So we had a separate line for the dialysis. Then we had the mechanical ventilator and then the ECMO machine. And we used the CardioHelp ECMO. So how do we manage these patients? They were all put in ICU. Then we had our ECMO access. Majority were on femoral. We did hemodialysis or CRRT and hemoperfusion using an internal jugular triple lumen catheter. We gave our patients all methylpred and cyclophosphamide, and they were all given sedation, anticoagulated with heparin, monitoring our PTT and ACT, and transfusion of various blood products as needed. And this was patient 1. He was a 47-year-old male, and you can see his very severe X-ray with his pre-ECMO showing a PF ratio of 62. His PO2 was 62. That's already on maximum ventilation and PEEP. And 1 hour post-ECMO, this was all corrected with a PO2 of 435, better control of acidosis, and CO2 at acceptable levels. For this patient, we used CRRT plus HP using the 330 cartridge. We did CVVH. She's a 60-kilogram male. We used 1,800 mils per hour pre-dilution substitution at a predicted dose of 30 cc per kilo per hour. And we retained the blood flow of 100 to 150 mils per minute. Patient was on systemic anticoagulation for ECMO, so no additional anticoagulation was given. Fluid removal as needed, and we continued CRRT until BP normalized and he was off inotropes, then shifted to SLED. We used HP using the 330 cartridge once a day for 3 days. In some patients, a 4th or 5th dose was done if HSCRP increased, and we monitored using SOFA scores, HSCRP, and procalcitonin daily. Here, to show you the serial SOFA scores of all the patients, the mean value is the one in red. And this shows that there was a steady decline in SOFA scores as the patients improved. Here, we also monitored procalcitonin, trying to look for what marker we could use to show improvement. And again, showing to you, they all start with very high procalcitonins, and then it steadily declined with time, as shown in the mean value. Again, the red line after every hemoperfusion. Sometimes the patients will come and develop hospital-acquired pneumonia. So sometimes the procalcitonin would increase again. And so these are some of the problems that we find when we use some of these markers. We also tried to do HSCRP, and you can see normal was 0 to 3, and in some patients it went as high as 250. And we were very happy though with the mean value as shown here, that it didn't show a very good response, or maybe this may not be the right marker to look at response to the treatment. Now, very interesting was its effect on the need for inotropes. And this table shows you the mean inotropic requirements and that they decreased even after the first hemoperfusion. So here were our mean doses, our baseline dose of all required triple inotropes to begin with, norepinephrine, dopamine, and dobutamine. And as after the first hemoperfusion, we find that the doses decreased for norepinephrine and dobutamine. And after the second, we were already off 2 inotropes. And after the third, again, showing to you that it was very effective in removing inotropes. We feel that it's possibly the hypotension could be because of acidosis, hypoxemia, increase in CO2, and cytokines that are released during this very early period. And that ECMO was able to control the CO2 and O2, the RRT, the acidosis, and we have the HP that controlled everything else. So it was really a very effective, since we were able to remove the inotropes, we're better able to support the patient's renal failure with CRRT. Many times we can't continue the dialysis because the blood pressure is just too low. But if we're able to improve blood pressure through this modality, then we're able to successfully proceed with our renal replacement. What is the renal outcome and patient survival? 5 of these 7 patients were lived. And here showing to you days off dialysis. So renal function occurred as early as 2 until 18 days. And days on ECMO were between at 1 to 2 weeks. And ICU days ranged from 15 up to 54 days in ICU, and hospital days as shown here. We had 2 deaths. Patient 6 came off dialysis early because there were bubbles that occurred in the ECMO and we could not put the patient back on ECMO. And patient 5 developed necrotizing pancreatitis. He needed to have an exploratory laparotomy and we lost that patient. So this is just to show to you the patient before and on the 6th day on ECMO that there is complete resolution with lung rest. So we know from leptospirosis the kidneys recover and the lungs will also recover completely. We have patient 2, again 36 male, no known liver disease, negative viral serology. He was a non-alcoholic beverage drinker. Ultrasound showed hepatomegaly with no biliary obstruction, severe acute pancreatitis. Eventually, this also showed walled-off necrosis, and his problem was a rising ammonia and decreased sensorium despite being off sedation. And here, when the ammonia went up to above 160, we put the patient on the ammonia cartridge, and the ammonia levels serially declined as the patient got better. We found that ammonia more than 150 is associated with cerebral edema and possible herniation, so we felt that there was indication to try this cartridge, and it worked, and this patient got better. Another patient, again, ultrasound showed normal liver and pancreas. He had stable pneumonia. This time, he had a rising bilirubin. Lipase was 10 times the upper limit of normal, and no sensorial changes were noted. And when bilirubin reached about almost 30, we put him on the bilirubin plasma adsorption perfusion. cartridge, and the bilirubin declined. So hyperbil more than 15 is associated with the development of bile cas nephropathy via direct bile toxicity and obstruction from bile cas, etc. So that we felt that the patient were sure his renal failure will improve with because with the leptospirosis, but if we have a bilirubin that's too high, it might cause further acute kidney injury. So again, we found an indication to try the bilirubin cartridge on this patient, and after just one treatment, the bilirubin declined. We had another patient though with again a rising bilirubin, and here after the first perfusion with bilirubin at a level of 30, we found that it still continued to increase. So we did a second treatment. The bilirubin then was about 45, and after that, it already declined. So conclusions, we found that hemoperfusion on patients with severe leptospirosis with renal failure and pulmonary hemorrhage, which we now know to be fully reversible, is a useful method to support the management of AKI in critically ill patients, and that the sepsis, bilirubin, and ammonia cartridges were useful to prevent further complications in these patients with multi-organ failure. Thank you very much.
So thank you very much. I will have some questions, but we will get the discussion at the end. And I think now we would like to hear from Professor Ngoc San from Vietnam, hemoperfusion on septic shock and acute pancreatitis. And again, we will have the discussion at the end.
Yeah, thank you very much for the kind introduction, and Professor Ronco for this opportunity for me to talk today. So I think that my talk is, I think that we have many things to share with, similar with what the previous talk. So it may become more easy to talk about this. And first, we're talking about the current situation of sepsis and acute pancreatitis in Vietnam. And we talk about the effectiveness of hyperperfusion and sepsis and pancreatitis. And for evidence, I think Professor Ronco already talked a lot. So it's yeah, very simple for me to just go over that a little bit. And we talk about a little bit about study in which we have done for and several cases in which we have treated the patient in Vietnam. So maybe here, I don't think many people know about Vietnam, so I just show a little bit about Vietnam. So Vietnam is a country, a small country in ASEAN, and very next to China. So I think every people see China, and maybe they think that Vietnam is also the part of that, but actually it's very independent from China. And see this, and we also have some patient with leptospirosis, but not so severe like in Philippines. And I think it's not so dangerous to go to visit Vietnam, because you can see a lot of beautiful scene in sea here, and we got a very long country, so we have a very diverse climate, and also very diversity in culture. So you see many minority people in the northern part of Vietnam, and see a lot of long beaches in which you can do a lot of activities. And Vietnam is actually quite a big country in ASEAN. It's about 100 million population, and we still a developing country with middle income, about $2,300 US dollars. And for male in Vietnam is very stressful, so they very shorter life expectancy in comparison to the lady. And we have some college, lady college from Vietnam in this room too. And for health expenditure is in the big problem for developing country, because of, we try to catching up with the very high demand, and but still because GDP low, so it's difficult for catching up. So population parameters in Vietnam is, I think, the same like a developing country. In we aging population, is a big problem, and now we okay, but I think 10 years from now we are not, we are a big problem, as similar like many countries in Asian and of course in developed Europe and US. And for expenditure, we spend quite increasing the money in for healthcare system, but compared to many ASEAN countries in which we see Singapore here, we see Philippines here, we are still need do more to invest more for the healthcare system. So for the budget itself, we have not so many, but I think we need to, so the system is a co-share co-pay between the public and the family, the patient themselves. That's what become the big problem in case of they are very poor, so they cannot pay for the expensive treatment like we're talking about absorption therapy and ECMO or something like that. We have a long discussion with family members to decide whether to continue the treatment or we need to apply the new treatment for the patient. So sometimes it's very hard to persuade the patient to do, even they want to save their life. Here's some data to more detail about how we spend, and which now in Vietnam the public try the best, but also the private sector also increasing the contribution to the healthcare system. And I think that soon we will have very good health, very good private healthcare system in Vietnam, and which is good news for our people. Talking about the sepsis in Vietnam is a big problem because so similar like Philippines, we are in a tropical climate, so we have a lot of patients with sepsis. In general population, about 5 to 7%, and also the leading admission to the medical and surgical ICU about 10 to 30 to 23%, with a very high mortality in general, and especially in now we have a lot of patients with a multi-drug resistant pathogen, and it causes a lot of problem and complication, as well as a high mortality. And of course, a very high cost for broad spectrum antibiotic, cardiovascular monitoring, which we try to use for the patient, hemoperfusion or prolonged ICU hospital stay, and multiple disease episodes of hospital-acquired pneumonia. For acute pancreatitis in Vietnam is also the main. In some ICU, it's up to 22%, and most of the cases relating to alcohol. Some numbers go to the 66%, and we have very few cases of obstruction or hyperlipidemia or something like that, with high mortality and morbidities. In a case of with necrotizing pancreatitis, going up to 40% of complication and 20% of mortality, and has a really high burden for the family and society because most of alcoholism patient is very poor, so they cannot afford for the high treatment. We see that is very high in here, from 20,000 to 50,000 US dollars. So both of the sepsis and acute pancreatitis share the same pathway. You can see it in here with pathogen-associated molecular patterns or damage-associated molecular patterns, and it causes cytostorm, in which we have mentioned earlier about a lot of increase of the markers, in which we see very common in many patients. For the we look at how we measure those biomarkers. It's not easy for the developing country because we also have to pay a lot for the biomarkers, and sometimes the patient have to pay themselves. So in Vietnam, we do more with interleukin-6 concentration measurement, but other than that, it's only stuffing for the study or some research. And so many things we see in here that with very different in molecular weight, and it's very complicated. So for the treatment itself, we have 3 different kinds: hemodialysis and hemoperfusion or hemoperfusion, in which we see that for the very usual hemodialysis, we can get rid of some part of this, and for hemoperfusion, and it's the best we see in the hemoperfusion with large range of the molecular weight of the cytokine and get in this we can remove. And for the absorption therapy, we have both the system in Vietnam. We can do with standalone, or we can do with a combination with CRRT. And recently we tried for some patients with a standalone system, and it's quite working quite well. Only in case of the patient with hemodynamic stability, so we can try to do that. So we know that very well-known study, Eurofet, the trial, talking about the endotoxin removal, and with the result published in 2018. And this for the patient with septic shock with a high level of multi-organ failures, and they measure the endotoxin activity as a with the high greater than 0.6 included in this study. And the result is very disappointing. We see no significance in the mortality. And however, in subgroup or per protocol analysis, we see the group of EAA greater than 0.6 to 0.9 show the reduction in the mortality. So it has something to do with the study to show that maybe because of device capacity or because of the patient selection, sometimes it's causing the bad result or bad outcome. So that's why we need to choose the right patient and right time. For the this one, I think Professor Ronco already talked a lot, so I just skip, and we skip this one. For indication in Vietnam, we do this is a list of complication indication, and we use very often for the septic shock patient and for the acute necrotic pancreatitis. And now we try for several indications a little bit earlier, like patient with some strong reaction, inflammatory reaction, or in the trauma patient. And this study also reviewed by previous talk by Professor Ronco. And that's a true study. We feel very hopeful because of they change the outcome, improve the outcome dramatically when we use hemoperfusion, in which we can actually save life, actually reduce hospital stay and ICU stay, and which we expect the best one. So this is the detail of the study, and we know that a lot of improvement in which we think the best is the ICU mortality going down, or hospital mortality, but it's not so significant in hospital mortality. And another study for the sepsis-induced acute lung injury also showed a similar result, and this also reported. So that's why we try to several study in our country, and in which, because of cost, we cannot do kind of a multi-center or randomized control. So we just look at the safety and effectiveness of interleukin-6 removal in the patient treated with hemoperfusion. In this, at that time, we have only cytosol for the study. So we choose the patient with sepsis, 3 definition of septic shock and adult, and after that we try to cytosol, and we see that very significantly in the group of cytosol, they can reduce a significant level of interleukin-6 very dramatically after 72 hours. So another study we try on 330 for severe acute pancreatitis. Similarly, we choose the patient with acute severe pancreatitis, and the patient also under the CVVH, and we choose a cytokine level, high level, greater than 1,000. And this is a result to show that the reduction of the interleukin-6 is very significant in the group of treatment. And also we see the change in blood pressure stable, and lactate level also improvement. So several case, this is the first case for the 8 patient who admit to our department because of hypertension, and they did the SCAT scan in the previous hospital, and they make a diagnosis it's liver abscess, and they cannot treat the patient, and they send the patient to us. And we are tertiary center, so we receive a lot of patients like this, and very severe, and they cannot treat the patient at local level, or they need to refer. So on admission, the patient is quite senior alert, respond to command, and she has a little bit tachycardia, and oxygen, low oxygenation because this patient puts in on the mask, and blood pressure is a little bit low, and because the patient is actually on the vasopressor and inotrope with a very high dose, and on examination of the abdomen, we found the patient have tenderness and regarded to the palpation, and so at the same time the patient has some sign of cellulitis and ischemic blister on the back. For the lab test, that show that the patient is a very hyper neutropenia, and for correlation, tests show that the patient have a very high DIC score, and for test for the renal function, it shows that the patient have renal failure, and interleukin level is very high, more than 5,000. So we did the CT scan again, and we confirmed that the patient have fluid collection in the peritoneal space, and we culture, and we found some the bacteria for that. So the patient basically have acute pancreatitis, and they're very severe septic shock. And we treat the patient with the antibiotic, and however, the first day the patient condition still getting worse, and we need to increase the dose of vasopressor, and the condition of renals and DIC is still getting worse. In day 5 and day 2 and day 5, we need to intubate the patient and put on the mechanical ventilation, and we continue to use the patient with CRRT, and we use the cartridge 330 for 3 days. And after day 10, the patient can weaning, and we can extubate patient from patient. And we look at interleukin 6 level. We can see that after HP, the concentration of both the interleukin 6 and PCD level going down, and the dose of the vasopressor and inotrope also going down after we do with AP. The second patient is acute pancreatitis. It's a male, 34 years old, and he had history of acute pancreatitis for 7 months earlier, and he's actually the alcoholic patient. One day before admission, she had the sudden sharp pain on the epigastric region, and he admitted to the local hospital, and then the patient had to transfer to our hospital. So he came in the with what's coma scale of 15, and a little bit tachypnea and lower oxygen. And when we check for the abdominal examination, show that he fully very high pressure, distension and tenderness. And for the lab test, it showed that the patient is very high level of amylase, and lactate level going up to 5, and creatine level going up to 200. And we did the abdominal CT scan to show that the patient had nephrotic pancreatitis, and SOPA score of 11. This is clinical progression of the patient. We see that first days we measure the abdominal pressure very high, and that's why we need to range the fluids from the abdominal cavity, and at the beginning of the 2,500, and it's going down after the day after that. And we also check for the the blood test, coagulation test, and same thing with, before and after we do hemoperfusion, and we see that in here we see that it's quite okay for the coagulation profile. And the other marker we can see in here, we see the number of interleukin 6 going down after we did hemoperfusion. And another test in that we take care and we pay a lot of attention, that is platelet, because when we do the hemoperfusion, the platelet number can go down, so we monitor that one, and it do going down. So it's going down to 70 and 60, and after that we do not need to do any platelet or blood transfusion for that, but that later on it's going up. So in order to be successful, we need to look at many factors in the patient. First, we need to choose the right patient. That's the patient in which we can do very good at source control, and we do very well with early and appropriate antibiotic. And that patient we need to do very well with septic shock resuscitation, and the patient is not so severe, so we can measure the kind of markers like endotoxin or cytokines, or the patient with we can measure the severity of sepsis and septic shock, like severity score, like lactate or PCT. And we need to choose the right time because before that is irreversible multi-organ damage. So we better choose it earlier, maybe within 2 hours after we give the antibiotic for severe sepsis. And we need to have the right protocol in which we need to target. We need to have the target like endotoxin removal or cytokine removal, and we need to have enough or appropriate treatment duration and dosing. We need to continue for 2 or 3 days of the filters, or we need to have the very good strategy of anticoagulant or combination treatment for the patient have the multi-organ failures. So in conclusion, sepsis and acute pancreatitis are the most common cause by ICU admission in Vietnam, and treatment for those problems represent most difficult and costly for the healthcare system as well as patient family. Hemoperfusion is a shown promising option for those patients, and hemoperfusion could effectively lower level of most cytokines. However, it's not dictated to the outcomes of the patient yet. Choosing the right patient, right protocol, and right timing is essential for successful of the treatment. So with all that, thank you very much for the attention.
Thank you very much. I would like to ask the two speakers to join me on the podium for possible questions. We have approximately 5 to 10 minutes. I have a question for both of you. In both cases, it is extremely important to have the right dosage of antibiotics for your patients. Did you measure the level of antibiotics? Did you adjust the dose of antibiotics in case of use of hemoperfusion? How did you manage this aspect?
For our patients, we gave ceftriaxone adjusted according to renal function. We do not measure levels of ceftriaxone. In some cases, if we give vancomycin, we're able to measure vancomycin and amikacin, but not for the ceftriaxone.
I think that in our case, if the patient have the hospital acquired infection and we need to use a broad-spectrum antibody, antibiotics, we need to measure the concentration, and we also need to consult with nephrology and clinical pharmacists for that.
Well, I have a good news because it is our plan to measure in our institute the antibiotic adsorption so that we can understand how to integrate the dose and to manage in these patients in which the dose is so important. Another message I have for, especially for young fellows, you have seen in Philippines quite high incidence of leptospirosis, but do not forget a possible diagnosis of leptospirosis in our centers, because in Vicenza, for example, we still see 5-6 patients per year, and it's important to make early recognition of the disease, because if you treat it early, you may not end up with severe complications. Any question from the audience? Please. You have to speak loud.
Of course, it's not a problem for me, don't worry. I have a question for Professor Ronco. You, a few days before, you told me you start with HA130 in your dialysis center. Have you ever problem with coagulation in process of hemodialysis with HA130?
Okay, the question is a little bit out of the scope of this meeting because it deals with the smaller cartridge, which is the HA130, that we use mostly in patients, for example, with high pruritus, high level of beta-2 microglobulin, or specific complication in chronic kidney disease. Yes, we have used this in a patient with intractable pruritus, and we actually, just by precaution, increased slightly the amount of anticoagulation, but we did not have any effect of clotting. As a matter of fact, you might have seen the picture. We measure always pressures and pressure drop along the treatment, and we didn't see any coagulation effect. Plus, we did not see residual of blood in the cartridge at the end. So I think it's a pretty safe treatment that you can do. And our experience is that we use a little higher blood flows compared to what has been suggested. So for example, in this patient, we used 300 mL per minute. Okay. So if you have to make a final statement on your use of hemoperfusion in your patient, what would be the message to our fellows?
Well, I think it has a very important role to play. As you mentioned in your talk, that we have to look at the patient and what's happening to them and what would be the best treatment for that certain period. And that the role of cytokines in many diseases is really very important. And now we have a modality that can help direct our attention to the removal of those cytokines. And it helps us treat the patient more holistically.
Very good. And you?
Yes, I think so.
We are gonna visit Vietnam now.
Yes.
Because we have seen it's too nice.
Yeah, that's true that sometimes we have the problem to talking to the patient because of they need to pay. Sometimes they need to pay by themselves. So I need to have very strong evidence that is the effective treatment for the patient. So first we need to base on the markers and which we can that have available in the hospital, and we always do that before and after the treatment. And secondly, we need to see that whether patient change the patient condition is improving or not. So sometimes when we treat the patient for second or the third, but we don't see any improvements, we need to stop because we cannot talk to the patient and cannot persuade the patient at all. So that's why monitoring the patient is very important for us, and we have many things to monitor the patient for cardiovascular monitoring, clinical monitoring, and something like that.
With this, I thank Jafron for organizing this nice industry-sponsored symposium, and hopefully we will have more results in the 38th Vicenza course next year, because we have several ongoing studies, and I think this is an area that deserves a lot of research. Thank you very much, and have a good lunch. Thank you very much.